It's my pleasure to introduce an up-and-coming leader in our field, Angela Lamarca. She's a medical oncologist at the Christie NHS Foundation Trust and the University of Manchester. She won the Elizabeth Darden-Stefanin Memorial Fellowship for her research on the biomarker work with the ABC-06 trial. It's really important when we do these trials to learn from them and get smarter. And so I think it's fantastic that in such a large trial that there was such a commitment to collecting the biomarkers. So really looking forward to your talk, Angela.
Okay, thank you very much, Lipika, for the introduction, and thank you very much also for the opportunity for presenting our preliminary results. So what I'm going to present are the preliminary results of a grant funded, of course, by the Cholangiocarcinoma Foundation. The grant has been ongoing for around 6 months, so I'm just going to give an update of what are we doing and which preliminary results we have. So as we all know, biliary tract malignancies are a wide number of cancers. Of course, cholangiocarcinoma, but also ampullary malignancies and also gallbladder cancer. All of them have in common that they do respond to platinum chemotherapy, such as cisplatin and oxaliplatin, as very well has been summarized earlier this morning. And it's important that we understand why they respond and why some patients do better than others. And that's why we were interested in the DNA repair, in the DNA damage repair. It has been mentioned many times over this conference, the DNA damage repair, and is really important for platinum agents. In summary, and especially for the lay audience, I would like to explain why is it so important, the DNA damage repair. What happens is that every cell has a method to make sure that the DNA is properly copied when the cell is going to divide. If there is a damage in the DNA damage repair, we are going to have a lot of mutations and we may develop a cancer. When we have a cancer cell, if there is a problem with the DNA damage repair, we may have a better response to chemotherapy. And that's why it's important to understand these genes. The ABC-06 clinical trial is a randomized trial. It's a phase 3, and it has been summarized earlier this morning. Patients were randomized to FOLFOX chemotherapy or active symptom control. And the importance of this trial is that we were also collecting blood samples and tissue from these patients. As it has also been said, we have completed the recruitment for this clinical trial earlier in January this year, and we have randomized up to 162 patients in total. What we aim to do with this translational project is to investigate about the DNA damage repair prevalence in these patients and to check whether there is an impact on patients' outcome. We were including all patients recruited into the ABC-06 clinical trial, and we were requiring at least a 20% of tumor content within the tumor sample. This is a summary of the flow of the patients. All patients will have a diagnosis based on a biopsy or a cytology, will then be diagnosed with an advanced stage of the biliary tract malignancy, and will start chemotherapy with cisplatin and gemcitabine in the first line setting. When there was a progression to this chemotherapy, when the cancer was growing despite this treatment, the patients were offered to enter into the ABC-06 clinical trial, and here is where our observation starts. Patients who enter the trial and who are randomized will receive FOLFOX chemotherapy or active symptom control, and this allows us to prospectively assess whether the DNA damage repair has an impact in the response of chemotherapy prospectively, but also retrospectively, and assess the response to the previously received cisplatin and gemcitabine chemotherapy. As I said, the primary objective is the prevalence, how many of these patients recruited into the ABC-06 clinical trial do have a mutation in the DNA damage repair genes, but also we want to link these damage repair genes with the outcome of patients. Are we able to identify patients who will respond better to a platinum-based chemotherapy based on this gene expression? At the moment, the ABC-06 clinical trial, and it has been mentioned earlier, is still under follow-up, so we don't have any final results. The data are also currently under quality check, but we were able to retrieve demographic data on also response to platinum for the first line of chemotherapy, to the cisplatin and gemcitabine for the purpose of this presentation. For the ABC-06 clinical trial, one of the randomization factors was whether the patients were refractory, resistant, or sensitive to platinum, and that was based on the progression-free survival that they had to the first-line treatment. This slide is summarizing the flow of the work that has been happening over the last 6 months. All samples were centralized in our biobank in Manchester, and a pathologist with an expertise in HPV was going to review the samples and make sure that in all the samples eligible there was at least 20% of tumor present. Then, based on slides from that tumor sample, the DNA was extracted and a library was prepared, and all the samples were then sequenced in the Illumina MISEQ instrument. It's important to say that for the purpose of this study, we were only reporting class 4 and class 5 variants, which means that we are only reporting variants that we know are pathogenic or likely pathogenic, and that we are excluding all variants which are of uncertain significance. This is a summary of how many patients have been approached and how many samples we have at the moment. In total, 284 patients were approached regarding the ABC-06 clinical trial, and 162 were randomized. Up to September 2017, we were able to retrieve 42 samples, and out of these, 29 were eligible, and 23 are already being analyzed and are the results I'm going to show you today. As expected, around 70% of the patients recruited into the ABC-06 clinical trial do have a sample eligible for analysis, which is more or less what we expected. I'm not going to go in detail through the demographics, but as expected, the median age was 64.5 years. Most patients were metastatic and had a primary cholangiocarcinoma. This is a summary of the platinum sensitivity seen, which, as I said earlier, is a randomization factor, is an stratification factor for the ABC-06 clinical trial. And as you can see in the graph, is just separating the patients group quite nicely for the response to first-line treatment. Regarding the prevalence of the DNA damage repair mutations, 1 in every 4 patients had at least one gene mutated. We were testing 30 genes. It was a targeted sequencing, and from these 30 genes, the most frequent one mutated was the MSH6, which was mutated in 2 out of the 6 patients. And it's also worth highlighting that from the 6 patients with mutation, 1 patient had 2 mutations in out of the 30 patients analyzed. There is ongoing further analysis to check whether the presence of these mutations do have an impact in the response that the patient had to chemotherapy, and we will need to wait until all the samples are analyzed for us to be able to have any conclusion regarding that. In summary, what we can tell up to now and after the first 6 months of this fellowship and this project, the DNA extraction and analysis for assessing the DNA repair genes based on paraffin tissue in patients with advanced biliary tract malignancies is feasible. In around 70% of the patients, the sample will be good enough for analysis. And in one of every 4 patients, the analysis will identify a DNA damage repair mutation, which may have an impact for patient selection in the future, not only for platinum-based chemotherapy, but also for immunotherapy, which has been mentioned earlier in the talks. The next steps, that we do have still a lot of work to do. We do need to finish the analysis in all the remaining samples that have to be retrieved. We would like also to check the germline mutation, and that is planned in our time scale, and we will, of course, correlate the findings in the DNA damage repair genes with the response to chemotherapy, both retrospectively and prospectively. And I would like to say a huge thank you to all patients and family who collaborated in the ABC-06 clinical trial, and also those patients and family who at least considered taking part in the clinical trial. I would like to say thank you to my mentor, Professor Juan Vale, and also Professor John Bridgewater, both of them, of course, a part of the ABC-06 trial management group. A huge thank to all the translational ABC-06 group, which a long list of people that you have there in the slide, and of course the funding from the Cholangiocarcinoma Foundation and from the ASCO Young Investigator Award, the Concur Cancer Foundation, because they funded all this project. Thank you very much.
Thank you, Angela. We really look forward to that data.